Hello, and thank you for listening to our ISTAART PIA Relay podcast series, brought to you by NIHR Dementia Researcher. ISTAART is a professional society and part of the Alzheimer's Association, representing scientists, physicians, and other dementia professionals active in researching and understanding the causes and treatments of Alzheimer's disease and other dementias. In this 5-part series, we've asked members of ISTAART professional interest areas to take turns at interviewing their colleagues and being interviewed themselves. Confused? Don't worry, it'll all become clear as the week progresses. We'll be releasing one of these podcasts every day in the build-up to the Alzheimer's Association International Virtual Conference to showcase the work of ISTAART PIAs. Thank you for listening.
Hello everyone, and thanks for joining us to our final episode. I'm Sietske Sikkes, and I'm an assistant professor at the Alzheimer Centre of the Amsterdam University Medical Centers, and I chair the Non-pharmacological interventions PIA, and I'm also part of the subjective cognitive decline PIA. Today, I am very delighted to be speaking to Professor David Scott. Welcome, David. And can I start by asking you to introduce yourself and tell us in which PIA you are involved?
Hi, Sietske, and thanks very much for taking the time to talk with me and to talk about my PIA. My name is David Scott. I'm a professor of Anaesthesiology at the University of Melbourne and the head of the Department of Anaesthesia at St Vincent's Hospital in Melbourne. So as you can guess, I'm a clinical anaesthetist and an academic researcher into perioperative cognition. And that's where our PIA comes in, as I'm the chair of the Perioperative Cognition and Delirium PIA.
Okay, thank you. And as an anaesthetist, I can imagine that your focus in the past couple of months was on providing critical care and not so much on doing research. So I hope you've survived and are able to do some research as well. I wanted to ask you how you, if you could start by telling a little bit about your research.
Yeah, sure, Sietske. Look, it's a bit of a story really, and I guess it reflects what led to the formation of our PIA. You know, for a long time, and perhaps, well, easily for over 100 years, people have recognised that sometimes people don't wake up right after they've had anaesthesia and surgery, particularly older people. You'll often hear the story, well, mum was never the same after she had her surgery, whether she had her hip done or whatever she had done. And, you know, this went sort of uninvestigated for decades. And then with the advent of cardiac surgery, it became clearer that there were higher risk patients having more cognitive events, including delirium after surgery. But that was still studied in the context of anaesthesia research, rather than in the broader context of community psychology, geriatrics, or psychiatry. And a lot of work went into looking at what was called post-operative cognitive dysfunction. And from that, we decided in some of our work that when we were doing studies into patients, older patients, and assessing in collaboration with psychologists, assessing their cognitive function post-operatively, it was apparent that many patients going into these procedures already had some degree of cognitive impairment. They had some baseline cognitive impairment. We called this preoperative cognitive impairment or some other sort of term related to the surgery, but in fact it's just what they had in the community. And one of the highest risk group, of course, are patients who've got Alzheimer's disease or who've got mild cognitive impairment syndromes prior to that. And we basically needed collaboration with other investigators in other fields. We were working in silos. And the beauty of the PIA, as it eventually formed, was that it brought together geriatricians, basic scientists, anesthesiologists, academics, psychiatrists, a whole lot of people from a whole lot of countries. And that was because, I guess, hosted by the Alzheimer's Association. That's what it does. That's what Alzheimer's meetings are like. It's a whole melange of different specialties and specialist groups, and that's the opportunity to bring all the way from basic science through to clinical practice. So we started, to cut a long story short, we started from a question of clinical practice. Hey, my elderly mother's not been the same after anaesthesia and surgery. Well, what's causing this? And identifying that there's an at-risk population, that you need better tools for investigating it. And you also need to be able to look into the mechanisms underlying it and try and identify what might be modifiable risk factors. And that's where we got into delirium, because delirium clearly is something well known to you and to almost all of the listeners. And delirium is a very clearly definable clinical entity. It's defined in the DSM-4/5, and it can be measured by a number of screening tests as well as definitive testing. So that again, this idea of delirium after anaesthesia and surgery fell into place as part of this trajectory, if you like, of cognitive decline or dysfunction after anaesthesia and surgery. That's a very brief answer for you.
Well, thank you, David. That's very fascinating. And I was wondering, with regards to the mechanisms, do you how it works with the pre-operative cognitive dysfunction and post-operative dysfunction, whether they are separate, whether the anesthesia is what the effect is. Is it an accelerator, or does it independently cause the cognitive impairments? I was wondering what your... It's probably more complicated than one or the other, but I was wondering.
It is a bit of both, and that's a really important question, and one which we're wrestling with. It's also, I guess, one of the things which brought our basic scientists and Alzheimer's research into this fold, because a lot of the basic science, there is a lot of basic science looking at exposure of Alzheimer-prone animals, for instance, to, as in the amyloid mice and rats, to anaesthesia agents such as volatile anaesthetic agents and minor surgical procedures. And it could be shown that in those animals, they have changes in their neuropathology, which is accelerated by the exposure to the anaesthetic agents. So one of the hypotheses is that exposure to anaesthetic agents may be an accelerant for neurodegeneration in some way. And it's like a detective story. So we're moving more into a balance now where there's a predisposition because you've already got some cognitive impairment, which increases your vulnerability. That's pretty clear. There may be something related to the anaesthesia and surgery, whether it's neurotoxicity from anaesthesia agents, or more likely, much more likely, the combination of the stress and the inflammatory response from the surgical and anaesthetic exposure, but particularly maybe the surgery, which then creates an exaggerated deterioration, if you like, or neurodegeneration. And we've done some really interesting biomarker work in collaboration with the members of the biofluid biomarkers group, which has demonstrated that certain biomarkers of neurodegeneration actually increase after anaesthesia and surgery for a period of time. And so there is potential for understanding the mechanisms, but I would be the first to say we're nowhere near being able to say what actually is the biochemical or neurochemical mechanism underlying something like delirium. So you asked, are we accelerating it, or are we just making it sort of follow its own trajectory? And there's two things happening, aren't there? And you would know this from your own research into clinical archetypes and the clinical pathways of patients with Alzheimer's and other neurodegenerative diseases, that sometimes it's something like having an event happen that brings it to awareness that that person is only just barely coping in their own environment. So there's just in that case, the event, the fall, the fracture, the anaesthesia and surgery, yes, it's stressful, but actually what it's revealed is their underlying lack of reserve. But there is this other question, well, maybe if we modify that stress, we can improve the trajectory for some of these people.
Yeah, I think what you're saying is indeed the revealing aspect of of the surgical procedure, that's indeed something that you often hear in clinical practice. And is it also that that you apply this knowledge in your clinical practice? Back again?
Well, yeah. So with our group, the PIA has published a couple of white papers looking at both basic science and also clinical science and recommendations. And we've worked with the Perioperative Brain Health Institute of the American Society of Anaesthesiologists in producing some recommendations for care for patients, older patients having anaesthesia and surgery, as European groups as well. And basically, I think we do know there are things all the things you can do to decrease delirium are good things to do. And you know, there's lifestyle modifications, there's environmental modifications, there's removing predisposing factors, there's modifying precipitating factors. And from an anesthesiology point of view, which is, I guess, where I come from at my core, there are things like avoiding certain drugs such as benzodiazepines, avoiding pain, avoiding exposure to anticholinergic drugs or analgesics, which increase sedation, creating a familiar environment, trying to, you know, avoid metabolic disturbance, and maybe even modifying the depth of anaesthesia so that you're minimising the dose of anaesthetic that you give to these older patients. Now, there's conflicting evidence at the moment regarding some of the tools we use for measuring that, and it's, you know, there's plenty of scope for new investigators to get into this field because there's so many unanswered questions. But we use a form of EEG monitoring, processed EEG monitoring under anaesthesia. One of the forms is called BIS, but there's other types as well, entropy, and they give us an index of how much the anaesthetic agent is affecting the brain. It's to do with the fronto-parietal connectivity. And so we can, to some extent, dose adjust anaesthetic amount to older patients by noting the BIS, but it's not designed for that, and it's a rough tool. And at the moment, the jury is still out, I would say, on the recommendations are that you minimise anaesthetic dosing, and that makes a lot of sense. But whether that tool in itself is the key, we're still investigating. But there are so many other things we can do. There's regional anaesthesia versus general anaesthesia, but almost always when someone has a regional anaesthetic, I'll come back to the fractured neck of femur again because that's a typical situation. You know, they might have a spinal anaesthetic, but they might get some sedation as well.
Yeah.
So that clouds the whole clinical pathway. And, you know, so that's where orthogeriatrics really has come into its fore. I think it's one of the best demonstrated effective perioperative ways of minimising adverse cognitive outcomes in elderly patients.
Yeah, I think that's, it sounds like a very broad research field in itself, and it's really fascinating, but very difficult to oversee the consequences of indeed minimizing the medication people receive. I think that's very, yeah. I'm also thinking about pain perception and how people can communicate pain, for example, especially in the Alzheimer's disease stage, in the dementia stage. Yeah,
you're exactly. Yeah, I mean, you've hit the nail on the head. In fact, so that's where the human side of it comes in. You need to have people who know that person, who are able to communicate effectively with them when they're at that extreme. So the Alzheimer's, you know, the advanced Alzheimer's disease is obviously a very challenging situation for patients and their families and carers, and for clinicians trying to care for them. But I guess what we really want to do is to alter that trajectory, alter the path, try and stop people getting so much Alzheimer's disease, and that's what Alzheimer's Association is all about, and that's what we're all working towards. I know you've done some work, I think, into if almost cognitive preconditioning, or trying to enrich the person's mind or their brain before to see if that improves their trajectory. Is that a correct thing to say?
Yeah, yeah. So we looked a little bit into the non-pharmacological intervention of sort of lifestyle changes, and specifically for those people who experience complaints, memory complaints, because often these people would like to do something about their cognitive functioning. And we give them some general lifestyle advice, but with this project, we really wanted to develop targeted lifestyle advice. And I think, I think that's quite key in giving lifestyle advice and hoping that people will improve, is that it is targeted.
That fits in with some of the research that our founding chair of our PIA was Professor Liz Everett, and currently she's at Weill Cornell, but she actually works in my department in Melbourne as well. And she's got a research program which is just starting up now. It's been stopped because of the COVID situation that you alluded to right at the start. But basically it's to do with all those sort of psychological knowledge and mind improvement prior to anaesthesia and surgery, to see if that protects you against the stress. So we've heard of physical preconditioning before surgery. This is cognitive preconditioning, if you like. And she uses the term, cognitive rehabilitation. And so we're hoping that's exactly what I think you're talking about, and that's maybe you two should get together and talk.
Yeah, exactly. That sounds like a perfect match, actually.
Because you did talk about the challenge of COVID, and one of the problems we have as researchers in clinical practice is you've got to sit down with patients and do assessments on them. And at the moment, that's a touchy area. People don't want researchers coming into their homes, or sitting down with them for 15 minutes or half an hour, or an hour and a half, doing a psychological screening thing. So we've actually had to stop some of that assessment. And we're looking at ways it might be able to be done remotely. Remote assessment is something which is emerging, I think.
Yeah, actually, it's have always been in favor of remote assessments as an add-on, so to say, but it was very difficult to convince people about the need. But now, of course, it's completely clear we need remote assessments, even if it is just to follow people over time, to have some idea about how they're functioning whilst not being able to visit them. So it is, and it is, of course, it provides so many opportunities to do remote assessments. People can do that on their own computer or even on their own mobile phone, and you can capture a lot of data about how they're functioning. So it is definitely an area that I think a lot of people now see the value of and the urgency to work on. Yeah.
We've been motivated to do a lot of things a lot more quickly in different ways since we've had the limitations put on us, haven't we?
Yes, for sure. Yeah.
It was very unfortunate the meeting was cancelled, for instance. I'm sure everyone was hoping to come to Amsterdam this year.
Yes, that's very unfortunate. And I was actually looking forward to being a Van Gogh museum tour guide, but unfortunately that's also not happening. So we're very sad that you all won't be coming to Amsterdam this year, but hopefully next time.
Hopefully soon.
Yeah, and I was also wondering whether in the PIA you also have early career researchers involved, and or how they can get involved in your PIA.
Yeah, I think one of the beauties of the PIAs is that they're fertile ground for early career researchers to make contacts, to make connections, to get involved. There's a whole lot of different ways. Of course, joining the PIA is a good thing through ISTAART. Putting in abstracts and tagging them for the PIA. So what we did last year, we had a couple of people who we didn't know who had tagged our PIA as part of their submission to AAIC, and we invited them to present their work at our PIA Day as brief abstract presentations, which was a great way of getting to know younger researchers and for them to get to network with a whole range of people from, as I said, from basic scientists all the way through to clinicians of varying different specialties and expertise. So certainly putting in abstracts, tagging for the PIA is a great way. And everyone's is equal. There's no sort of academic hierarchy, I think, within the PIAs. It's just people who work together and can talk in a room, can go out to dinner, can have. We do have PIA-wide PIA-wide advertised webinars, which are held every year or so. We've not been that good this year. We had one last year, but we haven't had one this year yet. But of course, we'll be having both the live webinar at following the AAIC meeting, as well as these pre-recorded and pre-recorded sessions as well. I think your peer is probably doing the same. One of your peers, perhaps both of them.
Both of them, yeah. Oh, but good. So there will be a pre-recorded session that people can.
Yeah. So our peer, the Perioperative Cognition and Delirium peer, is putting together what I think is a great pre-recorded program, and we'll also have a live program for later on where people can interact with people who are registered with ISTAART. So. Yeah. As I understand it, the pre-record is going to be widely available for anyone, but you need to be registered for the live session. So there's that, and the other thing is we do offer travel grants for younger investigators, young investigator awards. And we advertise for those. There wasn't much, we couldn't really offer a travel grant this year because no one's traveling anywhere, which is, so maybe it'll double in value for next year, I don't know. But we're wide open to people just joining and paying and watching what we do, looking up researchers in their own area and coming along obviously to the ISTAART PIA Day.
Yeah, and that's an excellent initiative. So people can, with the fellowship, people can join who otherwise wouldn't be able to attend the conference. I think that's really great. Okay, well, I think our time is up, so thank you. And before we go, I have one final question. And I actually thought this was the most tricky question, but what advice would you give to any aspiring scientists out there who are thinking of looking into dementia?
That is a hard question. I should have been prepared for it. I think looking into dementia, I think it's so wide ranging, it's so important, but it affects people at all stages of the disease, from mild cognitive impairment all the way through. I think the area to look at is in the early forms of the illness, to look at, if you're looking at clinical patients who are just starting to get memory complaints, have mild cognitive impairment. I think that's a fertile area for research. Clearly, we want to do what we can to halt or even reverse more advanced dementia. But if you look at the analogy with cardiovascular disease, we achieve a lot more by preventive strategies and strategies which improve the cardiovascular system, improve the brain as well in cognition. But prevention, statins stopping it before the disease starts, before you have your heart attack, before you have your brain attack or your delirium, those sort of things I think are worth targeting. Delirium I think is worth targeting as well. I think that's a very important area, probably because not only is it a manifestation of some degree of cognitive challenge, but also an episode of delirium probably does some harm. And so it's likely that any strategies which can be done to prevent delirium will be of benefit. And if you can be the basic scientist who discovers the underlying mechanism for delirium and can turn it off, then that would be fantastic.
Yeah, so that's an open invitation to all early career researchers. I would like to thank you very much, David. It was a pleasure talking to you. And thank you for listening.
Thank you so much for listening over the past week. ISTAART PIAs are a great way to expand your network and find new collaborators, and we hope these podcasts have inspired you to become involved. You'll find profiles on today's panellists and information on ISTAART on our website at dementiaresearcher.nihr.ac.uk and also at als.org/ISTAART. We're looking forward to next week's AAIC virtual conference, so if you haven't already registered, visit als.org for more information. Finally, please remember to like, subscribe and leave a review of our podcast on iTunes, Spotify, our website and everywhere else you find your podcasts. Thank you again for listening.